All right. It's nice to meet all of you. My name is Nathan. I'm a neuropsychologist at WVU. I specialize in concussion management, so I'm based out of Wheeling Hospital. And today I was asked to give a talk on adults with TBI, which is a fun topic. So I'm going to start by sharing my screen, see if I can bring up my PowerPoint presentation, and then we'll see if we can get it started. Okay, let me see. All right, can everybody see that?
Yep.
Okay, perfect. All right. So just as a very brief overview of what we're going to talk about, we're going to start by talking about so TBI is a very large spectrum of injury, and it can range from a mild injury that should resolve within days to weeks to a very severe injury that can leave people with very severe, very permanent disabilities. And so in adults, we've got less research than we do with the pediatric population. Where we bump up against the limits of the research, we'll try to talk about that. But we'll also talk about the things that are evidence-based, both for mild TBI and then for more moderate to severe TBI in terms of management. What may come through clinic, what you may see day to day, whether it's general practitioners, psychiatry, or just things we may see in clinical treatment. So we'll talk about mild TBI first. Mild TBI ends up making up approximately 75 to 80% of all head injury cases. And so we'll spend a bit of a disproportionate amount of time talking about mild TBI. Just as a disclaimer, I have an absolutely terrible judge of how much time it takes for me to get through these. So this could be very quick, it could be very long, or it could be something in between. So I tend to make more slides than I need. So we'll see what I get through. I was told about 30 minutes, so we'll aim for that. If I'm short, we'll go through a case that I tacked on at the end. If not, I'll try to keep this at about 30 minutes. So with that, let's jump into the diagnosis of TBI. So there's several different ways that TBIs are diagnosed acutely. Typically, the most common one that we'll see used is something called the Glasgow Coma Scale. That was developed in the 1970s and has been used in emergency settings since then. And so if you want to look down at kind of the bottom right of the screen, that may be too small for you to read off, but essentially we're asking questions about consciousness. Can they respond? Can they answer questions? Are they oriented to where they are? And so a mild head injury, maximum scale score is 15. A mild head injury, a mild concussion, mild TBI is interchangeable terms. But is considered mild if it's a 13 to 15. If there's a loss of consciousness, generally considered less than 30 minutes in this case. In this scale, it's up to an hour. And then post-traumatic amnesia, so a period of time where they don't remember anything less than 24 hours. And so that's considered, using the Glasgow Coma Scale, a mild TBI. Moderate TBI is when their GCS score is in that 9 to 12 range. And typically we're looking at the lowest score over a 24-hour period. So somebody might be okay immediately, but then if they have a brain bleed and they tend to decompensate, then they may have a lower GCS score by the time they get to the hospital or they're in an inpatient unit. So we're usually going to use the worst score over the first 24 hours. So 9 to 12 is a moderate TBI, and then 3 to 8 is considered severe TBI with a longer loss of consciousness and a longer period of post-traumatic amnesia. Very occasionally, we'll see these injuries where it's a mild TBI, it's a GCS of 15, but they'll report a longer post-traumatic amnesia. In those cases, we're so, in absence of positive imaging findings, we're still going to consider that a mild TBI. Other groups, so like for neurosurgery, for example, there's this brain injury guidelines, big, so big 1, big 2, and big 3. And those are looking at things like, not only loss of consciousness, but also whether there's brain bleeds in very specific areas, the size of those brain bleeds, and whether they are multiple or singular. And so again, neurosurgery is going to have a slightly different way of looking at their categorization of severity of injury. And then the last one, which is not used as commonly, but you still see it some places, is the Mayo TBI Severity Classification System. And so they're going to use that Glasgow Coma Scale, again, within those first 24 hours. But anything that has positive imaging findings, they classify as a moderate TBI. One of the things we'll talk about later is what we call complicated mild TBI, which is where we have otherwise a concussion or a mild TBI, but the presence of small brain bleed. And so using the Mayo TBI scale, that would be considered a moderate TBI. Most of the time, those are considered what's called a complicated mild TBI. We'll go through very briefly just the pathology of mild TBIs first. So mild TBIs are considered essentially a neurochemical change that we see without that macroscopic neural damage. So we get a biomechanical force imparted to the brain that results in neurological signs and symptoms. There's an ion flux and indiscriminate glutamate release. Essentially what happens is these small pores get opened greater than they're supposed to be, creates this what we call mechanical poration, and it produces these sublethal pores in the membrane via trauma. You see an efflux of potassium, influx of the calcium and sodium, and these cells get hyperpolarized. They have a harder time firing. Outside of the cell, the brain senses that neurochemical change, and it restricts blood flow. And so if you look into that top right picture where it says neurometabolic cascade, we can see that there's a spike in neurochemicals outside the cell and inside the cell, but the cerebral blood flow drops in that first 24 hours. And we see it stay low during that period of recovery, up to about 7 to 10 days post-injury. In mild TBI, we see this axonal stretching that happens. There's this energy crisis. We see this change in cerebral blood flow, which we can see on certain types of imaging, where we see acutely, if we compare it to non-brain injured patients, we see that evolve over the recovery from injury. So if we look at the first 24 hours, we're already seeing some of that blood flow changes occurring. But when we look at 8 days post-injury, we can still see very significant and evolved changes in cerebral blood flow over that period of time. So at 8 days, we see it specifically, really more diffusely across gray matter than we do in those first 24 hours. Symptomatically, most of the time, we're going to see the symptoms from concussion begin immediately after injury. When we look at the research on delayed onset from symptoms of concussion, we're usually looking at a 24 to 72-hour window, depending on the study you look at. So we wouldn't expect new symptoms to start at this point, but we do see changes in blood flow in the brain through that recovery period. So the way that we evaluate and diagnose concussion is a little less specific because there's no universally accepted diagnostic criteria for concussion or mild TBI. The closest one we have right now is the American Congress for Rehabilitation Medicine, and they've put out in 2023 sort of a consensus statement on what we're trying to use for diagnosis of concussion, and in absence of that, we call it suspected concussion. Essentially, what it comes down to is that we need a mechanism of injury. So could somebody have hit their head hard enough to move the brain inside of the skull to create that neurometabolic cascade? Somebody bumps their head on something pretty lightly. If we're not moving the brain hard enough to overcome the cushion that is cerebrospinal fluid, if they're not doing that, then we don't have a mechanism. And sometimes we'll see in clinic patients that report concussion-like symptoms, but there's clearly no mechanism of injury that could have caused a concussion. So the first thing we need is a mechanism of injury. Second thing that we're looking for is either signs of concussion. Those are things like post-traumatic amnesia, loss of consciousness, et cetera. Or in the absence of those, then we're looking for acute symptoms, headaches, dizziness, light and noise sensitivity, cognitive complaints, et cetera, in conjunction with and or laboratory findings. And so that's the only one that's a little bit difficult, is that based on their criteria, we essentially can't definitively diagnose a mild TBI if we're sort of seeing it 2 weeks, 3 weeks, 5 weeks, 6 weeks, whatever, because we might have a clear symptomatic report, symptoms consistent with a mild TBI, but we wouldn't have gotten acute laboratory findings. And so that's the only challenging part with that. Otherwise, we call it a suspected mild TBI. There's multiple tools that we can use for evaluating mild TBI. One of the ones that I like the most in the general practitioner setting is that acute concussion evaluation, ACE. It covers a lot of the things that we're going to very briefly touch on here. But one of the things that we found with concussion and predicting recovery from concussion are that there are a number of pre-existing risk factors that put individuals at risk for longer recovery with concussion. Those are things like pre-existing migraine history, mood disorders, et cetera, and the ACE screens for those, as well as loss of consciousness, prior concussions, recovery time, et cetera. And so you, in a pretty brief form, you can get a good snapshot of what we might expect from a recovery. That's a really good form. And it's less applicable for adults, but best is a balance, and it's a balanced scoring system. We usually see that mostly used in the sports settings because it loses its sensitivity and specificity to concussion pretty quickly, about 72 hours, but it's often used on the sideline. Same thing with SCAT 5 and 6. You're generally going to need a baseline for using those. And so we see that predominantly in the sports setting, along with SWAY, although we're starting to see SWAY, which is a tablet-based balance and cognitive testing system. We're seeing that more and more outside of the sports setting, although it's pretty popular in the sports world. But again, it's very limited research on SWAY. And so we're still waiting for a little bit more of that to come out before we use it definitively. And then the vestibular ocular motor screening test is one that we use in clinic. It's really easy to do. It doesn't require anything other than just running the patient through some ocular tests and then some vestibular tests. And that has a pretty unique incremental validity. It's adding stuff that we're not getting from balance testing or cognitive testing in terms of diagnosis of concussion. So in adults with MTBI or concussion, so those are interchangeable terms. We use them interchangeably here. So in adults with concussion, they generally speaking have a worse timeline of recovery than we see in a pediatric population. There's a variety of reasons for that, but the general consensus, when we look at multiple meta-analyses on a mild TBI, is that if it's an uncomplicated mild TBI, so there's not positive imaging findings, we would expect complete recovery to occur around that 3-month mark. And it doesn't mean most people are going to take 3 months. The vast majority of people are going to recover in the weeks after the injury. But once we get to 3 months, the metrics that we look at in terms of frequency of symptoms and cognitive testing and things like that, those are generally going to be consistent with control groups in these studies. So for example, one of the studies that would be popped into one of those meta-analyses, just as an example, you can see in the bottom right here where we compare individuals with orthopedic injuries to a control group. And we see at 1 month post-injury, all of the scores on these neurocognitive tests, there's no statistically significant difference in those. So even though at times we see patients that will continue to report symptoms beyond that period, when we actually put them through more extensive cognitive testing, they generally test about the same as individuals who had orthopedic injuries. And then really once we get to the 6-month mark compared to orthopedic injuries, we're not seeing difference in complaints of cognition, fatigue, mental health, et cetera. One of the challenges, though, is that a lot of these symptoms that do pop up in the acute period are things like headaches, fatigue, mental health challenges, et cetera. And so there can be some misattribution of the onset of those with this injury. And we'll talk very briefly about that. So for interventions for persistent concussion symptoms, which is one of the things I want to focus on, it's a minority of concussion cases, but it's what we're trying to prevent. Most of the time with concussion, these are going to resolve pretty quickly. But there's things we can do to reduce the likelihood that a patient's symptoms persist for longer than we would want them to. And so the first thing we'll talk about is just some of the things that we tend to do that are evidence-based in a clinic acutely. Then we'll talk about some of those risk factors for more protracted recovery, how we try to head those off, or in other cases, address them when they come up in clinic. And then we'll talk about some more complicated mild TBIs. So the first thing that's important to know is that 10 years ago, 15 years ago, the way that we approached concussion management was we wanted people to rest. They rested until they felt better. They avoided symptoms. But over the last decade, there's been very, very consistent research, which has found in both adults and pediatric populations that if we're resting patients for longer than 48 hours, we are increasing the risk of their recovery time taking longer. Generally speaking, the longer we're resting them, the worse their outcome tends to be. There is now evidence of limiting screen time within those first 48 hours and just general cognitive activity for the first 48 hours. For a while, it was a very commonly recommended it was a very common recommendation that we were making to patients, but there really wasn't a lot of research evidence for it, either for or against it. There's really still, even now, only 1 or 2 studies that have examined screen time in those first 24 to 48 hours, but they do suggest that it does seem to improve outcome. And so we do want to take that period of about 2 days to rest, but resting beyond that can slow recovery. And so once we're transitioning out of those first 48 hours, the goal is to try to reintegrate as much of our normal activities as we can while managing symptoms with breaks. But increased symptom avoidance after that period can lead to symptoms staying present for longer than we would want. The other thing we talk about with patients, especially acutely, is that they're often worried that, hey, if I did too much today, I felt really bad the next day, I shouldn't do that much. And so spikes in symptoms are actually not associated with worse recovery time. And so one of the things that we try to encourage our patients to do is start reintegrating as quickly as they can tolerate after that rest period. Because when they do spike symptoms, if they do kind of a little too much, that doesn't necessarily slow down their recovery. Other factors like making sure they're increasing, there's a lot of increased stress around head injuries and return to work and things like that. And so being able to monitor those, being mindful for mood symptoms, utilizing coping strategies and outlets for stress when they have it. But then we also want to make sure we're monitoring that over time. And then sleep dysfunction and sleep regulation is another thing that I tend to emphasize a lot in my clinic, because sleep symptoms can be a symptom of concussion. We do see sleep dysregulation pop up very frequently after head injuries, but sleep dysfunction by itself in absence of head injury can also create concussion-like symptoms. And so often patients will get dysregulated sleep, and then they won't get re-regulated after their head injury, and that dysregulated sleep can either worsen or create concussion-like symptoms that last longer than we'd want. So that tends to be a point of emphasis as well. And then the other thing we try to do is get individuals doing some type of cardiovascular exercise as quickly as they can post-injury, once you're like 4, 5, 6 days post-injury, again, depending on orthopedic complaints, depending on pre-injury level of conditioning, depending on age, et cetera. So it's very case by case in terms of what we have them do. But cardiovascular exercise is the single most empirically supported intervention for mild head injuries at this point. And so we do try to emphasize that as often as we can with patients who are able to do that. I'm going to skip through this a little bit just to try to go through some of these things a little more quickly. But there's a number of factors associated with protracted recovery and concussion. So this is authored by Grant Iverson, who's based out of Harvard, who's probably the most preeminent researcher on persistent concussion symptoms in mild TBI. And there are a number of non-neurological factors that research has identified as being associated with protracted recovery. And there are other biological factors that we look at too, like especially in athletes, repeated head injuries. So the number of concussions is generally associated with longer symptom recovery and worse outcome. And so there are biological factors. There are also a number of non-biological factors, pre-injury factors, personal family history, mental health, et cetera. So we tend to try to be mindful of as many of these as we can as we're seeing patients with head injuries, because this is a balance between the psychological, the cognitive, and the physical when these injuries occur. And so from this same paper, which is a very, very good paper that came out today, the way that we think about these protracted symptoms, once they're outside that, in adults, 3 months, really in kids, more of like a month, but once they get outside that recovery window, we would say, hey, that pathophysiology, that neurochemical change from the concussion probably should have resolved by now. But the patient's still reporting symptoms. What could be the cause of that? We look at really this network, right? The symptoms that they don't necessarily rise from an underlying syndrome, but the symptoms are the syndrome when we talk about post-concussion syndrome. And so the other thing we try to be mindful of, especially from a mental health perspective, is depression that will pop up after mild TBI. We see a lot of patients that will report some form of depression that comes up after a mild TBI. But like with sleep dysfunction, it can be both a symptom of the concussion, but it can also create concussion-like symptoms. And so this is from a paper that is almost 20 years old now. But what they found is that when they look at individuals who don't have head injuries, but they have depression, do they endorse symptoms of concussion, right? Headaches, dizziness, nausea, fatigue, noise sensitivity, et cetera, cognitive complaints. What they see is that concussion-like symptoms are very common, very, very frequent in individuals who endorse depression symptoms. And so it's one of those things that we try to be mindful of from a mental health perspective. If we see those depression scores increasing as patients are going through recovery, we want to make sure we're addressing that as well. Like we talked about before, in terms of intervention for persistent concussion symptoms, if they're not recovering as quickly as we want, cardiovascular exercise tends to be the most empirically supported intervention. We also know that good education, especially early in that process, educating patients on what they should expect from recovery tends to be very beneficial. And there is some benefit for early intervention with psychological specific interventions like CBT and some group therapies targeting at-risk groups as well. Limited benefit with cog rehab, but they tend to group these with mild and moderate TBI. And so I don't love those studies whenever they group those together. And then vestibular therapy is another one that we see have an increasing amount of support. Most of the RCTs that we've done with those have been in the pediatric population. And then sometimes we'll see individuals use vision therapy. To date, we really don't have any good studies supporting vision therapy use with adult mild traumatic brain injury. However, there's some pretty good studies in non-concussion patients that have similar issues with convergence or accommodation issues. And so that's the thought process there behind why those are frequently used. And then the last thing we do, which I talked about very briefly earlier, is we really try to emphasize sleep hygiene. Sometimes you can use, if sleep needs to be re-regulated, melatonin can be helpful in pediatric populations relative to placebos. It did seem to re-regulate sleep a little bit faster. Things like CBTI, so CBT for insomnia, can be helpful. And there's at least one study that found blue light therapy was beneficial compared to a sham control with persistent concussion symptoms. I'm going to talk very, very briefly about work-related TBIs because these are things that we see come up very frequently. But just for the sake of time, I'll try to move through these quickly.
You have time, so don't
Okay.
feel like you're, yeah.
I was trying to get through this by 12:30, but I'm like, I can't get through all this in 5 minutes. Okay, so we're good. Are we good, Kelly? I don't want to when should I aim to finish up the talk?
Yeah, you're okay. Like 12:45 would be ideal so that we have time for questions.
Totally. Yeah, I'll get through this by 12:45. I was probably going faster than I had to. All right, cool. So we'll talk very briefly then about work-related MTBI, but I won't skip through this. But we see a lot of work-related injuries. I actually don't see that many. I know the data here will say that it's like 1/4 of the concussion population. My clinic is probably 70% pediatric athletes, and then the other 30% is split up between adult trauma, motor vehicle accidents, and some work-related TBI. But it's for me not 40%. But that's what the data says, is that when we look at large samples, they make up about 1 in 4 concussion injuries. Work-related claims for mild traumatic brain injury, we see a little over 1,000 a year based on some data from 2001 to 2011. When we look at people who have the hardest time getting back to work, we usually see freight trucking taking the longest, but in general, any activities where there's individuals who are at risk of re-injury on the job site, or they are participating in work that requires them to be climbing on ladders or walking on things. So, right, these are mostly 4 out of 10 of the top positions. The most lost time were construction related. That makes sense if we've got people on, say, light duty restrictions where they can't be lifting heavy objects over their head, they can't be climbing on ladders. That doesn't really fit with what their job is. But I think freight trucking has a high risk there, and I think from a liability perspective, individuals are often hesitant to say, "Yeah, you're cleared for work," when they're doing, freight trucking or some of these other construction jobs, relative to, say, someone who does an office job where their risk of head injury at work is probably a lot lower. From a return to work perspective, we do see that there is significant variability study to study and location to location in terms of how frequently people are getting back to work. So in Greece and New Zealand, for example, they were in the 80% had been back to work by week 1. In the UK, two different studies found 40% by week 1, 44% by week 1, 41% by week 2. So very drastically lower numbers than we see from some other ones. But when we look at 1 month post-injury, again, studies range anywhere from 25 to 100% of individuals are back from work. So it really depends on the country you're in, I think probably to some degree the culture around work. And for example, in some of these, they, regardless of how you were injured, if you miss time, then the government has a fund that they will pay you for your missed time. Whereas in the US, for example, you have to be injured at work to get money for that work-related injury. And so those can be factors. But one of the things we'll talk about too is that it seems that even when we control for that, work-related injuries do seem to cause people to miss more time than non-work-related injuries. So in this study, for example, they had 145 consecutive work-related head injuries at a university hospital come through. Some of these were students, some of these were actual like jobs. And so they just say, hey, if it's return to learn, that we're counting that for the students. If it's return to work, we're counting that for work. And they screened out anybody who was involved in litigation. I didn't mention this earlier, but unfortunately, litigation and return to work, like if there's a workers' comp case, litigation is the single biggest predictor of individuals not recovering with mild head injuries. And so, unfortunately, in those cases, they do tend to muddy the water in terms of research. So, we usually see those screened out. They fail performance validity testing at about 50% rate. And so, it just tends to muddy the water when we're looking at recovery time. So, that's why we see that screened out in the study. That's why it's important to note that was screened out. So, they completed these questionnaires, full neuropsych batteries. And what they found was 4 variables were significant for predicting the number of days to return to work. So it's age, multiple body injuries, intracranial abnormality at the day of injury, which would be more of a complicated mild TBI, and then the fatigue ratings. And then we can look at that chart here where we see that steady increase in return to work really over a 2 to 3 month window. But most of that big jump happens in that first week. I saw, I'm just going to pause for a second. I saw the chat, something pop up in the chat. If there are questions that people have for me, I can't see those. So feel free to just unmute yourself and ask, I think, is if they're allowed to.
Yeah. Somebody had just commented and said it makes sense. Um, if I was hurt at work, I would be less likely to want to return to work where I was injured, not as a physical health thing, but as a trauma response.
Yeah.
And then another one had asked if you could share the slides with us for us to update for
Oh,
them to
yeah.
look at later.
For sure. I'll send them to you as soon as we finish up. And absolutely, from a psychological perspective, it does make a lot of sense. And I don't know if I included it in this presentation or not. But one of the studies has found that there are, when we look at risk factors for increased, when we look at all those risk factors for increased recovery time with concussion, one of the ones that we see is that when there's an external locus of injury, so somebody injured you by their negligence, whether it's an at-fault motor vehicle accident or somebody did something at work that caused you to get hurt, we see significantly more symptoms in those cases. But we also see from a return to work perspective that how supported somebody feels at work also impacts how comfortable they are reintegrating into that work setting. And so, especially if you got injured at work and it was somebody else's fault and you don't have a good work environment and things feel pressure, your boss is giving you a hard time, it makes sense those people are going to feel challenged getting back to work. Whereas somebody who's maybe injured at work and there's a very supportive environment, they can make accommodations. We can make sure that we're working with the team supporting them. In those cases, they're usually a lot easier to reintegrate back into work, in my experience. So the person's correct. It makes sense to me as well. Okay, let me see if I can go to the next one here. So we're just gonna kind of move through this one because there's repeating some of the same stuff that we talked about before. Risk factors include things like anxiety and depression at intake, level of disability rating at intake, and then they look at people who hadn't been back to work a year later. Those tended to be risk factors for that. We also see in general that when people are injured at work, whether it's head injury or other types of trauma, burn, et cetera, that work injuries occurring at work tend to have longer recovery and they tend to have a harder time getting back to work. So it's not specific to concussions, but we do see that in other areas as well. And so even some people say, oh well, it's like a compensation thing, but even when we look at studies like in New Zealand where individuals their compensation is covered, so 80% is very similar to what we see with workers' comp. Generally speaking, workers' comp will cover 80% of your normal salary, your normal work hours. Even when we see comparable financial compensation, we still do see that work-related injuries were more likely to impair functioning specific to work and work participation in general. Next thing I just have like 1 or 2 slides on, I think, is what we call complicated mild TBI, which is that on a spectrum of TBI, right? So when you think uncomplicated mild traumatic brain injury, individuals who experience that neurometabolic change, but without macrostructural damage to the brain. Complicated mild TBI is one in which, for example, those other, at least one classification would call this a moderate TBI, But complicated mild TBI is when we otherwise have a concussion, is really diagnostically when we have a concussion. All the other criteria meet for a concussion. Maybe there wasn't a loss of consciousness. Maybe they don't have any post-traumatic amnesia. But then when we do a head CT, there's positive brain imaging findings. And generally, these tend to be fairly small and specific and focal, but there was some type of brain bleed that occurred as part of the injury. So we don't want to just classify these as uncomplicated or sort of normal mild TBI. And so most of the studies will refer to these as complicated mild TBI. One of the challenges in some early research with mild TBI is that these were being included with mild TBI when we looked at long-term recovery time. And so that does tend to muddy the water a little bit. But a recent meta-analysis has really found that these fall in this very distinct range. And this is looking specifically at cognitive functioning, but also in other studies, symptomatic recovery has found similar results, which is that compared to uncomplicated MTBI, again, what we're looking at here in this graph is essentially just z-scores, right? So sort of standard deviations below where the uncomplicated mild TBI group is. And so if it's falling to the left, what that tells us is that they're doing worse than uncomplicated mild TBI at 3 months. Is sort of less than 3 months on the left and at 3 months on the right. And so when we're looking at recovery time and what patients should expect with complicated mild TBI, it tends to fall a little bit more in that in between mild TBI and a moderate TBI. So next we'll talk about moderate to severe TBIs. These make up about 20% of head injuries, but from a financial perspective, they are the much greater in terms of long-term cost for healthcare. In terms of injury severity, these are the ones where we'll see a relatively high rate of death in individuals who do survive. We can see significant rates of disability depending on the severity. These can be anything from relatively mild deficits that we would consider a moderate TBI to individuals with severe deficits who need 24-hour care or who have significant supports in their community living. Often these are going to require surgical intervention. I'm not exactly sure the rates at which we see neurosurgical interventions. I do think that's evolved over the last 10 to 15 years. But neurosurgery acutely will see these patients and then weigh on whether they need to do some type of craniotomy. Often what happens is there's a bleed into that closed space, and because the brain has to go somewhere in a closed space, that as the bleed grows, it starts to compress the brainstem and can lead to death along with swelling and other things. So neurosurgery will usually watch the patients. They'll get repeated CTs. If it's growing, they may have to go and do a craniotomy, remove the skull to relieve the pressure, evacuate the blood, etc. Diffuse axonal injuries, so significant injury to those white matter tracts, are very frequent in moderate to severe TBI. And what we see is this sort of stepwise increase. So they grade diffuse axonal injuries. And the sort of first level is just below that cerebral gray matter. And then the second level is in the level of the corpus callosum. And then that third level is of the brainstem. And what we see is that they have significantly worse outcomes for each diffuse axonal injury grade, sort of about 3 times per increase in grade when we see that on MRI. And then when we look at autopsy studies, 100% of mortality cases had some form of diffuse axonal injury. Acute therapies for these often are going to include speech, OT, PT, and some form of cognitive rehab. Typically, these are going to be completed at a specialized rehabilitation hospital. A long time ago when I was in graduate school, I got the chance to work at 2 facilities like this. One of them was Kessler Institute for Rehabilitation up in New Jersey. So very large facility for spinal cord and brain injury recovery. And so that's usually where patients are going to get transferred to once they're stabilized acutely. Younger patients, like with most things, younger patients are going to have a lot better outcome than older patients when we look at community discharge versus long-term care facilities. And very similar to if anyone's worked with stroke patients before or any type of acquired brain injury, what we're going to see is that most of the time in those first 2 to 4 to 6 to 8 weeks, as the swelling goes down, we're going to see a good chunk of recovery. Over that first year, we're going to see steady recovery that tends to plateau a bit toward the end of that first year. And then some recovery organically that will occur between years 1 and years 2. And then at that point, a lot more of what we're looking at is functional recovery and accommodation, using the skills that were retained to be able to work around some of the deficits. So that's what we see here with this study. So Track TBI usually runs a pretty large studies where it's this big database, and Mike McRae published this paper a few years ago. And what they looked at was, hey, longitudinally, when we track these individuals from the time of injury, through that first year, what do we see? And one of the things that they found with this is that withdrawal of care. So very early on, even individuals who have what we call disorders of consciousness, so they were unconscious at the time, the prognosis didn't look, maybe great. That's where we see most of the individuals who pass away. But of the ones who had disorders of consciousness, so they looked at 78 of the 79 patients in a vegetative state at 2 weeks, eventually recovered basic verbal skills and basic communication ability. And so we are seeing significant improvement over the course of that year. And then of those ones, right, who weren't able to follow the basic commands at 2 weeks, 25% of them were fully oriented by the end of that first year. So we do see often significant recovery in this patient population, but they're also very likely to have some pretty significant deficits as well. And so from a treatment perspective, the things that tend to be emphasized are physical rehabilitation and cog rehab. So physical therapy for moderate to severe TBI tends to be a little more limited in terms of the research outside of acute settings. Some studies have found there's like a decrease in spasticity and contracture, but it doesn't last for very long. There was one high quality RCT that found some benefits of ballistic training. So ballistic training being more, we're pushing off of things. There's, I don't want to call it explosive training, but it's a little bit more intense than like walking or stretching. And those did seem to have some benefits even 6 months later when they came back and checked again. There's at least one study that found using balance training in VR tend to provide benefits for the moderate to severe TBI population, and then some benefit with mobility training, but the data is a little bit more mixed there. One of the things that's interesting to me is that in concussion literature, physical activity and specifically cardiovascular exercise is really the most empirically supported intervention for reducing both acute, subacute, and chronic symptoms with concussion. But we don't necessarily see those same benefits translate with a moderate to severe TBI. It's very frequent that individuals demonstrate respiratory dysfunction and exertion intolerance, which in anybody who's having exertion intolerance, there's going to be increased risks of health conditions and cardiovascular disease. And inactivity in general is associated with higher rates of morbidity and mortality, even within those first few years after injury. So there's a systematic review that looked at all of the studies that have been done with physical activity and moderate to severe TBI, but they didn't find as much benefit on things like balance, walking duration, fatigue, and quality of life by the end of those studies in that meta-analysis. There was some benefits to mood and cardiovascular health, but the effect sizes were so small, and they really couldn't make any comments about whether those persisted over time, whether it was limited to the time of the intervention. But one of the things that we do know is that there is a position statement from the American College of Sports Medicine, which has put out guidelines for individuals with stroke and brain injury, that fitness training programs were prescribed up to 3 to 5 times a week, 20 to 60 minutes. And then we're kind of capping it at that 40 to 85% of heart rate reserve. And that if done that way, that it's safe to do in these populations. But like with everything, it's especially in this population, we have to be mindful of things that can do harm, like falls, if individuals have significant balance issues. Usually in this population, it's done under the supervision of a physical therapist, as opposed to something like mild TBI, where we can have those patients obviously supervise themselves. Cog rehab actually has a lot of support in the moderate to severe TBI research. And what we're doing with cog rehab is twofold. One is to reduce the essentially just or organic dysfunction that's present. So trying to strengthen some of those impaired cognitive functioning. And the other is to use the skills that have been retained to develop some compensatory strategies. There's been almost 500 studies that have looked at cog rehab in the moderate to severe TBI population, and 93% of these studies reported some form of significant cognitive improvement in at least one of the outcome measures they were looking at. Most of these effect sizes are pretty large, And there's more recently some evidence that when we use what we call metacognitive training, paired with domain-specific interventions, that tends to help with generalizability. One of the challenges with cog rehab sometimes is that they can get better at these specific tasks that they're working on, but that doesn't always translate to other tasks, especially if they're in a group home or in their community living. Sometimes those don't always translate. Comprehensive rehab programs for moderate to severe TBI are wonderful when they exist. They're often hard to find. I did, again, a long time ago, get the opportunity to work in one that had both a residential and day treatment program for acquired brain injuries. These are great for the individuals because they provide their medical care, their transportation. It gives them the opportunity to socialize with other individuals who've got these acquired disabilities, while also being able to get physical therapy and cog rehab when appropriate. And when they're in these residential and day treatment programs, we see significant improvement in quality of life, reduced psychosocial problems, better community integration. We see high rates of employment, but often these are limited by what's available in your area. It looks like I'm coming up on 12:45, so I'll just try to wrap this up very briefly. Let's see if I can get through this slide in 60 seconds or so. Essentially, when we look at TBIs and the aging brain, so one, when we get to like that 65 plus population, there's very limited research on the sort of outcomes, but they just generally tend to be a little bit worse. It's a very understudied population. When we have a moderate to severe TBI, we do see a decrease in brain volume, and brain volume is generally associated with cognition later in life, especially when we look at hippocampal volume. That's often impacted by moderate to severe TBI. But there doesn't seem to be a risk, like an increased risk of like developing an Alzheimer's pathology, for example. So it seems like a lot of these studies suggest that essentially what's happening is that we're having these insults provide essentially they limit our reserve, not specifically cognitive reserve, but in some ways it's sort of general organic reserve. For example, some of these studies, when they tracked cognition in adults who had moderate to severe TBI over time, what they found was that the difference between controls and individuals with moderate to severe TBI on measures of cognition, that delta, that difference between the two of them didn't change over time, but individuals with brain injury were showing much more cognitive impairment because the decline for them was much more noticeable because of that initial insult. And so I am pretty close to 12:45. I'm going to skip the case example and I'll just go to questions. Anything I can answer for anybody about this stuff? I know we went through a lot of it as quickly as I could. Any questions I can answer for you guys?
Well, I have one question for you. First of all, I learned so much. So thank you so much. I was still operating in the rest for long periods of time modality. It's been so long since I read about TBI. So I really learned a lot today. My question is very focused. We spent a lot of time talking on sort of return to work where they're returning to the same role that they left. But I guess my question is maybe more and also maybe applying to kids, but for adults too. What about return to school or environments where they're continuing expected to learn new information and it's not just a return to the routine of the old? Are there some difference? And maybe like they're actively a college student or they're in some like training program to seriously learn some new cognitive task that is a different skill. Would any of these recommendations sort of change if the return was to like an active learning a new skill cognitively environment?
Yeah, that's a great question, Lauren. So I think the short answer is it depends on how far post injury it is, right? And so, for me, for example, like I see all of the collegiate athletes from Wheeling University, right? So we're very frequently working with the Student Services Center over at Wheeling University to make sure we've got academic accommodations in place for them, so that as they get back into return to learn, we're not doing it in a way that overwhelms them or that they're falling behind. We're making sure their teachers are aware of the challenges they have. But also, as they're getting back into sport, as their symptoms are coming down, they're using fewer and fewer of those accommodations to try to, to ramp things up. So in the same way that we want to ease people back into work, we try to ease them back into learning. If it's someone who, had an uncomplicated mild TBI, 3 months ago, and they're thinking about transitioning into it, maybe going back to school for something, that's a case where I'd say, based on the cognitive data, I wouldn't necessarily expect them to have any more challenges than they would, prior to the TBI. If they're having specific symptomatic reports, that's more case by case. But a lot of it just depends on how far post injury they are. Does that answer your question?
Yeah, thank you.
Okay.
All right, you had another question in the chat. It said, I know that quick intervention treatment is important. How do we encourage our rural populations to seek treatment to avoid the long-term effects of mild TBI or repeated mild TBIs?
Yeah, great question. So yeah, I was actually, I was one of, very proud of it. I was one of the authors on the paper, the first paper that looked at time to getting patients into clinic and time to recovery. And so it's one of the things that we do try to emphasize a lot. But for rural patients, what I would say is that there are always telemedicine options for rural patients to be seen acutely, and especially in West Virginia, that's one thing that we do. And I'm no way trying to promote my own clinic or anything like that, but like for example, for me, like all I see is mild TBI. Half of my clinic days are telemedicine, right? And so there's always usually going to be someone in the area, whether it's Charleston, Parkersburg, Wheeling, Morgantown, there's usually going to be some provider there who sees TBI and who's willing to do telemedicine. And so for those rural cases, what I would say is I think telemedicine options are probably going to be the best if you're looking to get into specialized treatment as quickly as possible. But in the cases where they're not, where they're unwilling to, I think sometimes there's only so much you can do with that. But telemedicine, I think, has done a lot for increasing access for patients to get in quickly. Great question. Any other questions I can answer for you guys today? I'll stop sharing my screen here.